Hello, welcome back to this series, which is about high-yield topics in MRCP exam, which is from medicine keys. And today we are going to talk about pneumonia. In fact, pneumonia is the most common infectious cause of death, and this is why pneumonia is high-yield topic not only in MRCP exams but also in any interview, in any job interview. Most likely they will ask you about pneumonia. So if we come to the classifications of pneumonia, there are many types of classifications. For example, they can classify it according to the causative agent, and other classifications according to the site of the lung which is affected. But to make it simple, in this page, it's classified according to clinical classification. But first of all, we need to know what's meant by pneumonia. Pneumonia, in fact, it's a lower respiratory tract infection. Because it can affect the alveoli, it can affect the bronchioles or the intersection of the lung. And this classification, you can see at the bottom, it's called the clinical classification. So clinically, pneumonia can be classified into community-acquired pneumonia, which is simply means that pneumonia occurred outside hospital, and the other type of pneumonia is called nosocomial pneumonia or hospital-acquired pneumonia, and the third type is aspiration pneumonia, which can occur both inside or outside the hospital. So if we come to community-acquired pneumonia, it's further classified into typical pneumonia and atypical pneumonia, and this is according to presence or absence of symptoms of pneumonia. So if symptoms and signs of pneumonia are present, it's referred to as typical pneumonia, while if these symptoms are absent, symptoms and signs are absent, it's called atypical pneumonia. And on the X-ray, this is radiological classification. On the chest X-ray, typical pneumonia presents as lobar pneumonia or bronchopneumonia, while atypical pneumonia it's interstitial pneumonia. And you will know what's meant by this in the next slides. So if we come to the second type, which is called nosocomial pneumonia or hospital-acquired pneumonia, this type is somehow important because patients who are inside hospitals, maybe they have a problem in their immunity, and also bacteria or pathogens which are inside hospitals, they are usually resistant. So the third type is aspiration pneumonia, and in medicine case you will find each type fully described in all details. So if we come to the next slide, which is about complications of pneumonia. Pneumonia can result in parapneumonic pleuritis and pleural effusion, and in this case you will hear frictional rub, and the patient will complain of pleuritic chest pain. And the second classification is emphysema, or the second complication is emphysema or lung abscess. This occurs when this pleural effusion is infected, and also pneumonia can cause ERDS or acute respiratory distress syndrome, and in severe cases it can result in respiratory failure and sepsis. So this is what they usually ask in the MRCP exam. They usually give you a scenario of an old patient with sepsis, and there are top 3 causes of sepsis in elderly. The first is pneumonia, the second one is urinary tract infection, and the third one is skin infection. So let's read the next part, which is about recurrent pneumonia. In people with recurrent pneumonia, we should think of lung neoplasm or obstruction, and this usually occur in the same location, meaning in the same lung, every time the patient develops pneumonia on the right side. So we should think that there is something wrong in this lung, which is most likely either obstruction or lung neoplasm. But if both lungs are affected, we should think of immune deficiency or Wegener granulomatosis. Wegener granulomatosis, the other name of it is GBA or granulomatosis with polyangiitis, and we remember it by the letter C because it's associated with C. ANCA. So C, upper respiratory tract, lower respiratory tract, and renal. So in the upper respiratory tract and lower respiratory tract, it can cause recurrent pneumonia. And the other note is it's saying that pneumococcal and influenza vaccines can be used for prevention of pneumonia. This is called the primary prevention, meaning it prevents occurrence of pneumonia from the start. So now we are done with the introduction of the pneumonia. So if we come to the first type of pneumonia, which is called typical pneumonia, and as I mentioned previously, it's called typical pneumonia because patients will have typical symptoms and signs of pneumonia, or simply consolidation will be there. So if there are signs of consolidation, we should think of typical pneumonia. And It's saying that strep pneumonia is the most common cause of typical pneumonia, and you should notice that strep pneumonia is also the most common cause of bacterial meningitis. And if you remember from the first slide, I was saying that typical pneumonia can be either lobar pneumonia or bronchopneumonia. Lobar pneumonia, as you can see, it affects only one lobe of the lung and it affects the alveoli, while bronchopneumonia, it affects both bronchioles and alveoli, and it's usually scattered and it affects both types of the lung. So if we come to the manifestations of typical pneumonia, the point which is very important is these patients usually have sudden onset of symptoms, meaning they will develop high fever and chills, and they can develop productive cough, and this cough is productive with yellow green sputum. Sometimes they call it as rusty sputum. This point is important, by the way. And also patients can develop pleuritic chest pain due to inflammation of the pleura, and they can have signs of consolidation. Because this is typical pneumonia, so we should find signs of consolidation, and these signs, if we want to classify it according to normal examination pattern, which is by inspection, what should we find? Actually, there is nothing specific in inspection. What about palpation? Palpation, we will find two things. The first is tactile phragmitis, and the second one is bronchophony. And we will know exactly what's meant by each word of this in the next slide. So by palpation, we will find bronchophony and tactile phragmitis. So if we come to percussion, it will be dullness to percussion. And the last point, which is very important, by auscultation. Auscultation, we can hear an added sound which is crackles. And you know, crackle is inspiratory. It's not like wheezes, which are expiratory. And we will find also bronchial breath sounds. This is very important. So in your exam, he may give you a scenario about a patient with typical pneumonia, and he can ask you what's the added sound that could be heard in this patient, and the answer should be crackles. So if we come to signs of pneumonia, just as a little explanation, so it will be dullness to percussion due to underlying consolidation, due to lung consolidation, and also tactile phragmitis. You know, we'll ask the patient to say 99. So you will hear it more than usual because voice travels more better in area of consolidation. And we can also find bronchophony. Bronchophony is the same as tactile phragmitis, but using the stethoscope. And the third one is bronchial breath sound. It's sound of air moving into bronchi, and it's higher pitch and louder than normal vesicular sound. You know, the normal breathing sound is called vesicular sound, but in cases of typical pneumonia, we should hear bronchial breath sound. And the third one, or the one before the last, which is egophony. Egophony is something, you know, it's very unique. When we ask the patient to say E and auscultate on his chest, we will hear it as A. This is due to consolidation. And the last point, which is late inspiratory crackles, which is popping sound when air passes through the fluid. And you should note that crackle also can occur in cases with pulmonary edema, which is a complication of heart failure, but these patients are not feverish. So if you find in your exam, if you find a crackle with fever, we should think of pneumonia, while if we find crackles without fever, we should think of pulmonary edema. So if we come to the diagnosis of pneumonia, so we'll find elevated inflammatory markers such as ESR, CRP, and procalcitonin. Procalcitonin, it's non-specific inflammatory marker, and it means that there is a bacterial infection. And if we do chest X-ray, we'll find lobar or bronchopneumonia. Lobar pneumonia or bronchopneumonia. These are the two patterns of typical pneumonia on a chest X-ray. And we can do something which is more advanced, like chest CT, if the chest X-ray is inconclusive, or in people with recurrent or resistant pneumonia, and advanced testing such as bronchoscopy and diagnostic thoracocentesis. And usually these tests, they are reserved for cases when a chest X-ray is not conclusive, or when we suspect that there is an underlying mass. So these are the two patterns of typical pneumonia in chest X-ray. The first one is lobar pneumonia. As you can see, only one part of the lung is affected. It's localized to a single lobe, and this is why it's called lobar. And the other pattern is bronchopneumonia. Bronchopneumonia, it's patchy area spread throughout the lung, and even it can affect both lungs. So if we come to the management of pneumonia, this point is very important. After we diagnose pneumonia, we should calculate curve 65 score. And the importance of this score is that it will determine which patient needs admission and which patient needs outpatient treatment or home treatment. So it's admission versus home treatment. Curve 65, C stands for confusion, for example, altered mental status, while U stands for urea, elevated blood urea nitrogen, more than 7 millimole per liter, and R is respiratory rate, tachypnea, it's more than 30, and then blood pressure, systolic blood pressure less than 90, and the last one is age, which is above 65. And every point of this will deserve 1 point. So, for example, if we have a patient who is 70 years old, this is 1 point, who is presenting with tachypnea, this is another point, and blood pressure is lowered, so this is a third point. So if we calculate these points and we find that it's 0 to 1, it means that we should treat the patient as outpatient or in home treatment. While if points more than 2 or more, so we should admit the patient to the hospital, because it means that his pneumonia is severe enough. So let's come to the next slide, which is about detailed medications. Which medications we should give to a patient with pneumonia. And by the way, this slide is updated. It's according to NICE guidelines. So pay attention to details here. So in outpatient treatment, you remember if curve score is 0 to 1, we can either give monotherapy or combination therapy if there is comorbidities. Let's start with monotherapy. If there are no other comorbidities, and a patient came with pneumonia and his curve score is 0 to 1, we can give either amoxicillin, doxycycline, or macrolide. Macrolide such as azithromycin or clarithromycin. And did you notice all of these medications are bare oral medications? So suppose if a patient has comorbidities, for example, he has COPD, he has decreased immunity, like patients with diabetes, we can give combination therapy or monotherapy with respiratory quinolone. Let's start with combination therapy. See, in monotherapy, we give amoxicillin or doxycycline or macrolide. So we can add something to it. Instead of amoxicillin, it will be co-amoxiclav plus either macrolide or doxycycline, like the monotherapy one. Or we can give respiratory quinolones, and pay attention to the word respiratory. Because, for example, levofloxacin, moxifloxacin, or gemfloxacin, all of these can be used because they are effective against pneumonia, and this is unlike ciprofloxacin. Ciprofloxacin cannot be used for treatment of pneumonia because it's not respiratory quinolone. So this is if the curve score is 0 to 1, but in cases of severe pneumonia with a curve score of 2 or more, these patients should be admitted, so it's inpatient therapy. And inpatient therapy, we usually give dual therapy or combination therapy. The first is 1-beta-lactam, which is IV, such as ampicillin, sulbactam, ceftaroline, ceftriaxone, or cefotaxib, plus either doxycycline, macrolide, or respiratory quinolone. So let's come to the next slide, which is about atypical pneumonia. And the other name of atypical pneumonia is walking pneumonia. You know why? Because symptoms are not severe enough. So patients are usually asymptomatic, or we should say symptoms are not very severe compared to their chest x-ray. The chest x-ray looks far worse than the patient condition. So the first note is mycoplasma pneumonia. It's the most common cause of atypical pneumonia. And if we have a look here, see the pattern on the chest x-ray, it will be interstitial. If we focus on this diagram, see these are the alveoli, and these are the bronchioles, and this is the interstitial tissue. So this type of pneumonia, it affects the interstitial tissue. This is why it's sometimes called interstitial pneumonia. And on the chest x-ray, it usually shows it usually manifests as patchy infiltrates on both sides of the lung. We will see this on the next page. So clinically, always think of comparing this type of pneumonia with the other type, which is typical pneumonia. So clinically, the onset will be slow onset of low-grade fever and dry cough. This point is very important, by the way. So atypical pneumonia causes dry cough, while typical pneumonia, it causes yellow-green sputum or productive cough. And then if we come to consolidation, it will be absent consolidation. And also auscultation will be unremarkable. So forget about crackles in this case. And what's important in this type of pneumonia is the extrapulmonary features. These people usually present with things outside the lungs, such as erythema multiforme. You see, it looks like a target lesion. And also they can present with encephalitis and Guillain-Barré syndrome, and also autoimmune hemolytic anemia. And this is why this type of bacteria, the Mycoplasma pneumonia, which is the most common type of atypical pneumonia, it can stimulate autoimmunity. This point is important, by the way. So if we read this note, it's saying that chest x-ray is worse than the patient symptoms, and this is why it's called walking pneumonia. And here, if you remember, erythema multiforme, it was associated with two organisms. The first is Mycoplasma pneumonia, and the other organism is herpes simplex virus. This point is very high yield. And also, erythema multiforme, it can cause cold autoimmune hemolysis. This point also is very important, and it plays a role in diagnosis, and this will be explained in the next slide. So if we think about diagnosis, if we take chest x-ray, for example, we'll find that the patient will have interstitial pneumonia, and we can do PCR for mycoplasma. This is the most accurate test, and serology will find increased immunoglobulin M. This is very important, by the way, and positive Combs test. I just need to add a note here. You know, autoimmune hemolysis, it can be of two types. The first type is called autoimmune hemolysis, while the other type is called warm autoimmune hemolysis. In cold autoimmune hemolysis, it's immunoglobulin M, while in warm autoimmune hemolysis, it's immunoglobulin G. And you can remember this by a mnemonic called cold ice cream is yummy, and hot weather is great, or warm weather is great. So cold autoimmune hemolysis, it's immunoglobulin M, while warm autoimmune hemolysis, it's immunoglobulin G. So if we come to treatment of atypical pneumonia, we should give antibiotics such as tetracycline or doxycycline, macrolide such as azithromycin or clarithromycin, or quinolone such as levofloxacin or moxifloxacin. And if you notice, all these antibiotics, they work against protein synthesis. They inhibit protein synthesis of the mycoplasma. You know why? Because mycoplasma, they lack cell wall, so we cannot use beta-lactam antibiotics such as penicillin or cephalosporin because the cell wall is absent. This point is very important, by the way. And the other note, it's saying it's not always possible to clearly distinguish between typical and atypical pneumonia. Thank you so much, and if you want to know more about all high-yield topics for MRCP exam and also solve flashcards in the form of questions and answers, please have a look at medicinekeys.com. Thank you.